So thank you very much for the introduction, Vaughan, and thank you very much for having me here. So I'm an occupational health consultant, and currently I'm working with a non-NHS occupational health provider. But when I first started with the PATcHWORK study, I was a consultant at Guy's and St Thomas's, and I continue to work part-time with GSTT to continue academic research. So here, as Vaughan said today, I'm here to present PATcHWORK, which stands for Patients' Views of Health and Work Advice Study. Okay. So this is just a slide to acknowledge the fantastic team that I've been working closely with on this study, and I'm immensely grateful for their input in this study. So as it says here also that the study has been funded by the Arthritis UK as part of the Arthritis UK Medical Research Council Centre for Musculoskeletal Health and Work. Okay. So just a bit of background as to why this study was conducted. So as we know, worklessness can exacerbate health problems, including poorer mental health and higher frequency of healthcare visits. Conversely, psychologically and physically safe work is generally good for health and well-being, and it can be part of a successful rehabilitation from ill health. Therefore, supporting individuals who are out of work or at risk of losing their work from ill health to remain at work is crucial, promoting sustainable working lives. A variety of health and work support services for people with long-term health conditions have been developed and evaluated. There's been different models of delivery. This is just some examples of them, and it includes the train and place and the place and train model. As an example of the train and place model, this includes like the former government work and health program, which provided training before job placement with some success in employment outcomes. But the more well known is the place and train model. An example of this is the IPS or individualized place and support. This is focused on finding paid employment for the individual, and then followed by vocational rehab support with skill development and health support. So as part of this is also a recent Connect to Work program launched by the Department of Work and Pensions, which is like a voluntary IPS-based employment program for those that are unemployed or at risk of losing their job. Other health and work support services include access to work and occupational health. So despite that there's a breadth of available health and work support, it seems like there's little is known about what patients prefer regarding how it should be delivered. But understanding the views of patients and stakeholders really is essential to design an effective and acceptable support model, contributing to the NHS Fit for Future 10-year health plan, which aims to integrate support from across work, health and skills system to help people find and stay in work. And this study also coincides with the recent government Mayfield report on keeping Britain working, Keep Britain Working, which recognises the need to support people with long-term health conditions to remain and thrive at work. And although the current evidence of effective practice remains weak. So really that brings us to the aim of this study, which is to develop a detailed understanding of how best to develop and deliver health and work support for from the patient's perspective. So really we want to understand the type of support that they want, the setting and timing to receive this, the mode of delivery and who should deliver it, how this support can be linked with existing services, and to what extent they think employers would be receptive to information on supporting their health at work. So in terms of methods, this is a qualitative study with semi-structured interviews. So participants were UK adults who were either unemployed due to the health issue, or they're employed but they were currently off sick or at risk of losing their job because of their health issue. So they were recruited through advertisement via our existing research networks and professional societies, and the aim was to recruit about 24 participants. So interested participants completed an expression of interest form, and they were subsequently screened for eligibility and then consented for the study. The interviews took place between November 2024 and February 2025, and it was either by phone or online via Microsoft Teams. The interviews, they were semi-structured using a topic guide, and this topic guide was informed by the study aims and the input from the University of Aberdeen Epidemiology Patient and Public Involvement and Engagement Group. So the interviews were conducted, transcribed verbatim, and then followed by inductive and deductive reflexive thematic analysis as guided by the Braun and Clark by 2 researchers, which included myself. Initial codes were developed by 2 researchers independently, which were then jointly reviewed, discussed, and then reflected in detail, exploring any differences and taking this into consideration to develop the initial themes. The initial themes were then further reviewed and refined jointly until overarching themes and sub-themes were achieved. So this is just to mention that ethics this research has been approved and sponsored by the Research and Development Department at GSTT, and then the favourable ethical opinion was granted by KCL Research Ethics Committee. So the results were we had 28 people that expressed interest in the study in total. However, 1 didn't meet the eligibility criteria and 2 withdrew because of ill health. And then 10 didn't respond to further contact. So we ended up with only 15 participants that consented to the study and completing the interview, which are then all included in the analysis. And the primary plans for proposed sampling was not applied. Of the participants interviewed, as you can see here, that they were mostly female of white ethnicity. 8 out of 15 of them were actually self-employed. However, there was a diverse range of work and geographical area that was covered. So the thematic analysis generated 6 overarching themes. The first 3 themes were actually related to health and work issues that we identified, and the other 3 themes are key factors to consider when determining suitable health and work services from the patient's perspective. This is just a table just to illustrate the themes, but don't worry, I will be going into them in detail, but just to broadly identify that the main health and work issues that that emerged were disability discrimination, the lack of health and work support awareness, and trust concerns. Health and work support factors that were important were flexible working, accessibility to the support, and the importance of the worker feeling supported and valued. So like I said, I'll go into this in detail. So starting off with the health and work issues. So the first main theme that was noted was disability discrimination. A sub-theme of this included the work disability stigma. So some participants reported adverse work impacts after disclosing their health conditions, including a job loss. And this is demonstrated by this quote on this slide. It says, "I do regret mentioning my health condition because I was treated worse at work for having that condition, but I don't think I changed my work. In fact, I think I was working harder. I would say more than having the physical condition impacted my work. I think it impacted how I was treated and the sort of relationship with my line manager really and how people saw me. They pushed me out of my role and then I ended up pursuing an employment tribunal, which I did win." And then that was one of the examples. And then it seems like the work disability stigma, the fear of this, is also affecting pre-employment stage, with some participants reporting that they were concealing their health conditions to avoid any prejudgment. Self-employed individuals also seem to share the work disability stigma because this included like some individuals reporting that they lost work after their business clients actually discovered like their health condition. For example, the next slide shows a quote from that demonstrate this. So here he said, So this is like a conversation between the participant and the business client. So he says, I think with disability, I've had some very bad experiences. I went to one client and he said, well, just to let you know, you'll have an absolute nightmare with parking. And I just said, oh, that won't be a problem for me at all because I've got a blue badge. And he kind of paused and stopped and thought and said, why is that? And I said, well, I've got multiple sclerosis. Explained the situation at that point, fatigue, and a couple of other things were issues. He said, oh, I didn't know that. We don't employ disabled people. Goodbye. So I thought that was quite an interesting quote, quite stark, to demonstrate, the disability discrimination associated with the health condition. Um, so another sub-theme that I noted under disability discrimination was disability visibility. So this is how visible someone's disability is. So many participants believe that the more visible their disability is, so say, for example, if, I don't know, they had a fractured limb, that's quite obvious, then they're more likely to receive workplace support. So their employer is more receptive or supporting them at work. Whereas those with less visible impairments, so say mental health condition, they seem to have felt that they were less supported. Uh, does that seem to affect manager support of workplace adjustments? It seems like the disability visibility did influence colleague relationship as well. So when work adjustment rationale wasn't visibly very apparent or obvious, this generated some adjustment envy from colleagues as well. And there was a participant that noted that this was actually worse from younger employees. So the other main theme was the lack of health and work support awareness. So this was noted at three different levels, the employee, employer, and medical specialist level. So in terms of the employee level, during the interview, it was quite apparent that many participants were unclear of what health and work support is and what is available and how to access it. So unsurprisingly, they actually expressed strong desires to have comprehensive health and work support information to avoid any sort of missing potential benefits. Um, there was and employees that didn't have access to occupational health may encounter more difficulties of accessing health and work support as well, like not knowing where to go. And even when individuals did have OH access, there was some delayed support that can arise, and that can be due to unawareness of workplace advocates or the existing policies. Some of the unawareness of workplace health and work policies were because they were poorly located. So it was very difficult for the employees to find them because sometimes they have to know exactly what terms to look for on their own intranet to find the policies. And if you didn't know, you just couldn't find it. So there is a general kind of like unawareness of health and work support of what's available within their organization, as well as support that's outside of their own organization. And then there's self-employed participants were also mostly unclear of what available health and work support as well, probably because they don't have the usual access to occupational health or the HR support that they would have with regular employment. So their understanding of what help they can get was largely shaped by their own personal networks. And then despite the limited awareness of what health and work support is, quite a few participants actually describe what they desire as a holistic health and work support. So like including workplace health promotion, any financial advice and support with signposting them to the relevant medical groups. In terms of the employer unawareness, so there's the managers, for example. Managers were some of the managers were unfamiliar with health and work support, and that can cause delay with employee support. So, for example, one of the participants, they actually waited over 14 months in getting support for a suitable chair. In fact, she was still waiting at 14 months to get this chair. And this is partly due to a delay in getting the occupational health referral. And then when occupational health made the recommendation of the chair, the manager was unsure about how to actually get this equipment. So there was the manager just wasn't sure what the process was in the organization and who to contact and actually get this sorted. So as a result, quite a lot of participants proposed that they would like management and senior leadership to have training so that they better understand long-term health conditions and how to access health and work support to actually help the employees. Now, in terms of employer unawareness, there's also participants that were business owners. One of the participants actually said that they believe many business owners are possibly uncertain about accessing health and work support for their employees. So this individual, for example, just wouldn't know how to access occupational health, even though she was interested how to um, uh, actually find occupational health relevant for her own employees. Um, and then there's a lack of occupational focus in medical consultations. So participants did suggest that they would like to have work discussions in their medical consultations with their GP or their specialists, even if it wasn't to give particular advice. I think it came across that they would like to have even just some signposting to how to get health and work support, or given like information sheets, or like having health and work support maybe even displayed in medical waiting areas so that it increases their awareness. What they said was a benefit of getting some advice from their own GP or specialist was the convenience and the familiarity that the physician would have with their medical problems if they discussed work during the consultation. Interestingly, though, one of the participants was actually a psychiatrist himself. So he said that he would like health and work support advice from his specialist with his patient hat on. However, as a clinician himself, he actually felt there was insufficient training to provide occupational advice, and he believes that occupational health is actually better placed to provide this advice. Uh, Another theme was the trust concern. So there was notable mistrust between managers and employees. So due to fear of different treatment, some participants withheld their health condition from their manager. And conversely, some managers may mistrust their employees because a participant believed that their occupational health referral was just to verify whether they falsified their condition or not. Some participants also believed health and work support advisors were actually aligned with employers, and so that might deter employees from seeking support. However, some actually did view occupational health as impartial, and for those that did view them as impartial, they did value their adjustment recommendations because it was seen as like a good form of evidence to justify their workplace support. Quite a few participants also expressed concern about medical confidentiality if they were to consult a health and work support advisor, especially if they weren't medically trained and they were accessing their health records. However, most of them felt that this concern can be mitigated if the health and work support advisors were medically trained, given the professional code of conduct and also because they're medically trained, they trusted their recommendations more. So then now I'll move